Good afternoon and thank you, ma'am, for including me in this IC. I know exotropia is a challenge. Karte raho, as she said again and again and again. We do it first and then again they come back with a residual exotropia and again you do. And sometimes you find again third time also you have to intervene. So we know that patients with exotropia who undergo surgery commonly develop exodrift over time. The reported incidence is within 2 and 4 years after primary surgery is up to 42% and 50% respectively. So post-operative drift is largely responsible for the higher recurrence and low success rate after surgery. So for us as a clinician, it's very difficult to predict the time of onset and rate of progression of exodrift. So we did a study at Shroff. So we looked up at the factors affecting residual exotropia after 2 muscle surgery for intermittent exotropia. So we took it at a 6-week post-operative visit after 2 muscles, and we found that it was a single surgeon, and we took as that the possible factors were compared between patients with residual exotropia more than 10 and successful outcome within 10 at the 4-6 week, and we wanted to find out the factors. So 17.2% patients even the 6 weeks had residual exotropia, and it was not affected by amblyopia, anisometropia, lateral concomitance, or pattern deviation or vertical deviation, or the type of exotropia or type of surgery done. What mainly it was because most of them are presenting to us very late. So the age of surgery, what we found was the most common. They're coming to us very late, and the preoperative deviation for distance. So it was when it was very high, large angle, that those were the children we found that there was a failure of 2 muscle surgery for intermittent exotropia. So there's another study published in 2021 also, which also reported a post-operative exodrift of 16.6%. So they also felt that 91.6% of patients underwent reoperation for post-operative exodrift. So means once it starts drifting, we have to reoperate them. So now what is the reason? So they have late age, and then you have a deviation of a basic exotropia of 45 and 50 prisms. We do our left eye recess resect, which is a surgical protocol, and we find that after the surgery the distance is 4 prisms and the near is 16 prisms still. So as they grow older, there's much more chance of convergence insufficiency. So we were discussing in one of our webinars, and Dr. from UK was saying maybe you should do in older people biomedial resections instead of doing a LR recession and a resection, which I did in one patient, but I don't think I would still prefer R&R surgery. So a smaller deviation gives you the better outcomes, like less than 40 prisms give you a better outcome, and they also already have good binocularity, like around stereopsis in 800 seconds of arc. So a slight overcorrection during the immediate post-operative period is better to avoid long-term recurrences. So now which is a choice? So more effective. There are many studies done, and they have proven that for more than 45 prism diopters, it's better to do an R&R, unilateral R&R surgery, and better survival probability is more in the bilateral recession group. So bilateral recessions have a higher success rate and lower recurrence rate. So it is recommended that now when we want to improve our success and our predictability of our surgical outcome, that we should measure the target at a distance, far distance test, that monocular occlusion should be achieved in patients before deciding on the amount of surgery, and that intervention should be performed for the largest angle. But I believe in prism adaptation test. So monocular occlusion alone does not give you the full angle. It is better to do a prism adaptation test. Now whether you want to do it for 1 hour or you want to, sometimes in some patients I give them for a month, put up Fresnel prisms and call them after 1 month. So this tells you the maximum, like do not want any residual. So this tells you the maximum angle of strabismus which you have to operate. And since the study is not published, I have not put it here. But we have found an 83.4% increase in our success rate after doing a prism adaptation test. So in our children, we had, in fact, they were all office based, where we put the prism for 1 hour and we rechecked them again, and then we operated for the angle after the PAT. So this also tells us, at the same time, it also helps in telling us whether there will be any post-operative diplopia. So it also helps in this. So frontal prisms can be used for this. So conservative management is basically orthoptic exercises and prisms. So we have a very good binocular vision therapy department, and so when there's a residual, we immediately counsel the patients to go in for vision therapy. And we found, like, we're also working on a study on this, and we found that maximum of our patients did not require resurgery, because most of them got controlled within 3 months of doing a binocular vision therapy. So it is important that we do vision therapy exercises, the box string or prism based out exercises, so that they improve over a period of, so they will definitely improve. And once they get the full fusion and the stereopsis better, they very rarely go back to exotropia. So surgical strategy, this was a very good article by The Art of Managing Recurrent Exotropia by Edward Buckley, and I found this a very useful the representation, where he said that if you have done a recess resect, you can go to the other eye, and if there's been a bilateral recessions, lateral rectus recessions, and with normal ductions, you can go in and do a medial rectus resection. And if there's a decreased abduction, then you avoid re-recessing the lateral rectus, but go ahead and do a medial rectus resection. So these are the different surgical modalities. So in this case, like, we have done the other eye, so you get a good result even once you operated the left eye, and you still have a residue, you can go and touch the other eye. Now, in such cases are there where you have no medical records, already operated twice, and then you have to go in and intervene. So you have to at that moment you may have to explore and find out whether the muscles, of course now we can do an MRI and an anterior segment OCT. I prefer an MRI because anterior segment OCT we don't have that facility in our place of measuring the distance of the muscle. And so we found that so we could do a reoperation. Why I'm putting this slide is, before I show this, I wanted to study what is the clinical course of even after you operate one recurrent exotropia, because always the parents or the patient itself ask us that 2 बार कर रहा है, अभी तीसरा बार भी होगा क्या? So then they want to know whether it will happen again. So this paper says that there is a reoperation, recurrence occurs even in them, like it's around 33%, but exotropia did recur, but they found that the recurrence rate was lower than that after the primary operation. So I think getting a good sensory outcome is so important, because if you just leave it like that, it will keep recurring and we'll have poor results. So now, what are the surgical options? Of course, we can do plication. So there's a small surgical video of a plication. So the options what we have when we have a recurrence is that I can do the other eye resect, and now plication also, this is I've shown a primary muscle, but small plications is good when you have to go in again to the same muscle, so that you don't have to, there's no big struggle in that. And so this is, of course, I use the technique of Dr. Pradeep Sharma. Like, I found this technique very helpful. So Sir does this technique, and seeing his video, I have just replicated that. He has put a wonderful video on YouTube. So basically what he says is that you need to go back to the center of the muscle, and that's why the effect comes. Because initially what I was getting a lot of under correction when I'm doing application. So now in this we need to go back. So when you go back to the same muscle, and instead of just tying it at the periphery at the insertion points, you need to go back to the muscle, and and when you do this, then you definitely get a good result. So we're not found, like, I get somewhat the same measurements now with plication. It is not we can safely say that we get the same result. But we need to do it in this particular manner, where we go back with the center bite and plicate the muscle. This Sir video is much better, so you can see it on YouTube. Like this is so I have adopted this technique and found good results. So surgical options, these are the few surgical options which I could think of, that we could do a plication also. Most of the people here, I think, have switched from resection to plication. I have not still switched completely, but I'm just seeing the results and seeing how much effect we are getting. So other surgery which we can do is that in residual exotropia is that this child has been operated already twice, There's been no documentation, and somewhere it has been written 9 mm recession of lateral rectus done. So only one surgery documentation is there. And so this patient had residual exotropia with aphakia, and now she wants to be hardly any vision in that eye, 1/60. So decided to go in for, so left eye also appeared big. So decided to go in. Now what else to do? I can't touch the normal eye, so go in for a transplantation. So in an exotropia, when you do in a normal exotropia also, like in a primary when you're going to surgery, when you all of you must have seen, when you take out that medial rectus, so by the time you transplant it and put it to the lateral rectus, it has become so small. So 8 mm resection also will give you around 4 mm of medial rectus resection. So I'm not really knowing how much effect I would get in this, because it was 45. So took the so what I did was that did a left eye, so already recessed 9 mm of lateral rectus. I was not aware, not sure whether it was already resected, but did a re-resection of around 8 mm. Took a, and so unless you do 8 mm or 7 mm large resection, you do not hardly get any piece. In spite of that, like I just got 5 mm of the medial rectus, and re-recessed it just to 2 mm the lateral rectus, and by the formula which has been published, paper by Dr. Ramesh and his team. This is how they have calculated that you get an effect of the medial rectus resection, you get around the 3 effect, and transplanted portion you get an effect of 3. And so calculating all that, I felt that it would get corrected by 45, and that's what I got. So I got a good outcome, but again the vision is poor. Whether it will drift again is a big question mark again. So because the patient is happy, she got married, so I think that's the story. So if there's time, we can show the video. Otherwise, it's a transplantation video. So transplanting. So this is, so you have to use a non-absorbable suture. So whenever you are, so you can't use an absorb, so use a non-absorbable suture. And this is the medial the lateral rectus. So that you dissect out the medial rectus. And so this cut portion, so when you have a lot of sensory skills, like when we go to communities, to secondary centers and to community hospitals, we find that most of these patients are having 60-70 exotropias or 60 to 70 esotropias. So I found it's a good option because you can do under local anesthesia where there is no facility of general anesthesia. They don't allow you to touch the other eye. And so I think it's a very good technique, at least in the last recent years, where you could do we could do a transplantation and save the, okay.
Thanks, Suma. Let that video play. But does anyone has any question to Dr. Suma?
Could you have done a plication here on a previously resected muscle?
No, it was fresh. This muscle was, when I entered, it was fresh. I mean, I just put peri there at the beginning, but it was fresh muscle. That's why you could do plication. Yeah, I mean, I'm not very like I know most of them have switched to plication now, but I'm little bit I'm still not sure of my results. So
Suppose it's a resected muscle.
Yes.
You could have done at least 6 to 7.
Yeah.
So if you want to do a second surgery, is it safer to do a plication than doing?
We can do plication.
But doesn't make, I don't know if resection.
But it could cause narrowing of palpebral aperture. So advancement of medial rectus would be a better option than plicating a resected muscle.
But advancement is already at 5, MR will be already at 5.5.
But even advance it, that is also a very strong procedure. Advancement.
It always depends upon what is the case we are looking at. So we can always placate. What happens is once you do a resection, the portion where you make a plication, it can be a little bit dicey sometimes because fibrosis will be there even at the anterior level. So still 4 or 5 millimeter is easily can be done. So we also have to see how much will be effective. It all depends upon how large the exotropia or residual exotropia. We can still do it. We have done it. That's where we also have published residual esotropia and exotropia, how transplantation helps. That's what we have done. But you can also do a plication in these patients.
The results with Exotropia I found are much better
They are.
than with
Definitely.
Exotropia.
Because of the arc
Because
of contact, it's much better. Always.
Also, you get a bigger piece.
Yeah, bigger
Yes.
piece, yeah, maybe, yeah.
Otherwise, 4-5 millimeters really is not making that much of a difference. You can get up to 8 millimeters.